Welcome. I'm Alan Giles, an emergency physician, and today we're going to look at some clinical cases that illustrate some electrolyte abnormalities. This is the first of a group of presentations, so let's get on to it. I'll just share the presentation with you. Now, I've called the presentation An Old Jewish Man, which I'll explain a little bit further down the track what I mean. Because let's face it, it's not an old Jewish man. It's a 70-year-old lady who presents to triage about 11:30 in the morning, and she's been brought in from a hostel, so not a nursing home. A couple of weeks of worsening urinary incontinence, some lethargy, and she hadn't opened her bowels for a few days also. Her local doctor had treated her with Careflex, thinking the urinary incontinence meant she had a urinary tract infection. But she worsened, and when her daughter went around there in the morning, she noted that she was confused, so brought her to the emergency department. A bit bradycardic at triage, a little bit hypotensive. Her blood sugar was checked, it was normal. And the GCS was 14 because she was confused. So, okay. She was seen by the emergency registrar, who noted that apart from reflux and psoriasis, she also had metastatic breast carcinoma, which had metastasized to bone. She'd had previous chemotherapy and was last admitted about 4 months ago to the hospital. So they had a bit of a background of her. Her meds, unexciting, some Nexium, some aspirin, some methotrexate. And she had this episode, it had been sort of over about 2 weeks. I said poor appetite, poor sleeping, had an open bowels, some vague abdominal discomfort, the urinary incontinence, and nothing additional. Wasn't noted to be febrile, with shakes or sweats that I knew of. Examination. Patient looked unwell. They were mildly confused, were afebrile but looked tired, and were clinically dry. Were bradycardic, they could see it with sinus rhythm on the monitor, and hypotensive, borderline for the age group. Chest was clear, moving all limbs, no evidence of a stroke, but was sort of sluggish to respond. Abdomen, which she complained of some abdominal discomfort, was tender to deep palpation in all area, but it wasn't considered a surgical abdomen. A rectal examination just shows some firm feces. So the impression by the emergency registrar was, as you'd expect, they thought, we'll go down the sepsis route first, but also thought, maybe this is hypothyroidism, and they clinically knew the patient was dry. So commenced some intravenous fluids, some normal saline, an ECG, some baseline bloods, most of them would be relevant. They added some thyroid function tests onto it. They started some ceftriaxone with the view that it could be sepsis as the cause. They didn't give gentamicin. They wanted to get an IDC in and get some urine away, and expected that this patient would have to be admitted under general medicine and would need to have a cerebral CT scan done. The bloods came back, and this is where it got a little bit more interesting, because you can see the blood tests here. First abnormality you can see is that the creatinine is elevated at 120. But more importantly, you can see that the corrected calcium is nearly 4, 3.9, so, and correspondingly, the phosphate is low. So this patient has hypercalcemia. And many of those symptoms we saw before were related to hypercalcemia, with the presumption that it's most likely going to become from metastatic carcinoma and her bony metastases. And in fact, they looked at previous bloods and did know that she was borderline elevated on last admission. So the treatment they've started, well, they've started the correct fluids, haven't they? They've got normal saline. Oh, this is the ECG that was done. The ECG shows they're in sinus. You can see the sinus rhythm there. They have essentially a right bundle branch block, but have a couple of things that do look like you get with hypercalcemia. They have an Osborn wave and a U wave. And the U wave seen in a number of different circumstances, such as hypokalemia, but it's also seen in hypercalcemia. The shortened QT isn't really shown here, I don't think, maybe because they've got a bundle branch block. So as we said, they've given some normal saline. They increased that to about 4th hourly, so 250 mils an hour. Then what else would you give? Well, they wanted to give some permidronate, which they gave reasonably quickly. You can give it up to, over 4 hours, 6 hours, and you give 60 to 90 milligrams to decrease the action of the osteoclasts. They didn't have access to zoledronic acid, which is a little bit more effective, so they went back to the old school permethrinate. They also started, because it takes a while for the permethrinate to work, they started something that works a bit faster, which is the calcitonin at 4 units per kilo intramuscularly. They didn't give any steroids, which you could, to decrease the absorption via the gut. So they changed it to immediate oncology and had a chat to oncology, and they said, look, let's repeat the calcium in 4 hours, see if it's in the right direction, especially with the fluid. I said, well, if you can get into euvolemia, let's consider it a loop diuretic when they're euvolemic, because that will help to flush out some of the calcium. And we'll consider using a monoclonal antibody, denosumab, which I don't know a great deal about, but it also inhibits osteoclast formation and bone resorption. And they'll review that and see if they decide to do it or not. Simple presentation. And why was it called An Old Jewish Man? Well, this is Gary Shandling, who's just passed away in 2020. And he had hyperparathyroidism. And he said, having hypercalcemia is like being an old Jewish man, which is why no one noticed it, he says. With me, I was an old Jewish man. And the symptoms are moans, because you just feel generally unwell, bones, because of the resorption, you can have pathological fractures, stones, you can have calcium oxalate stones, groans because of the abdominal discomfort, thrones, which I hadn't actually heard of before, and thrones is because you sit on the throne, the porcelain toilet, because you have constipation, but also you get polyuria. And psychiatric overtones because of the confusion, the lethargy, even going to seizures when it's really severe. So I thought that was an interesting way to remember it, like an old Jewish man. To complete this, I'm actually going to stop the PowerPoint presentation, and I've cut a part of the osmosis.org presentation of hypercalcemia, which I think explains some of the pathophysiology really nicely and goes through the treatment. So I'm just going to share that with you. So have a look at this, because I think you'll find it very useful.
Now, true hypercalcemia might be caused by increased osteoclastic bone resorption, which is actually the most common cause. And this is where osteoclasts, which are little bone-eating cells, frantically break down the bone and release calcium into the blood. This might happen when the parathyroid gland becomes overgrown and releases more parathyroid hormone. Another well-known cause of hypercalcemia are malignant tumors, some of which secrete parathyroid hormone-related protein, or PTHrP, a hormone that mimics the effect of parathyroid hormone, which stimulates the osteoclasts. Alongside these osteoclast cells, there are also osteoblast cells, which are bone-building cells, and some tumors cause osteoblasts to die off. Overstimulated osteoclasts without enough osteoblasts can result in lytic bone lesions, which are commonly seen in some malignancies. Another cause of hypercalcemia is excess vitamin D, either through the diet or through supplements, which can cause there to be too much calcium absorbed in the gut. Finally, there are some medications, like thiazide diuretics, which increases calcium reabsorption in the distal tubule of the kidney, which contributes to hypercalcemia. High levels of ionized calcium affect a variety of cellular processes, in particular electrically active neurons. Normally, calcium ions stabilize the resting state of the sodium channels, which prevents them from spontaneously opening and letting sodium ions enter the cell. With high levels of extracellular calcium, voltage-gated sodium channels are less likely to open up, which makes it harder to reach depolarization and makes the neuron less excitable. And this is what causes slower or absent reflexes, which is a classic symptom of hypercalcemia. The sluggish firing of neurons also leads to slower muscle contraction, which causes constipation and generalized muscle weakness. In the central nervous system, hypercalcemia causes confusion, hallucinations, and stupor. In most cases, when there's too much calcium in the blood, the kidneys try to dump it into the urine, causing hypercalciuria, or excess calcium in the urine. Hypercalciuria leads to a loss of excess fluid in the kidneys, causing an individual to get dehydrated. And the combination of hypercalciuria and dehydration can lead to calcium oxalate kidney stones. Hypercalcemia is diagnosed based on high levels of calcium in the blood, generally above 10.5 milligrams per deciliter. An electrocardiogram might show changes like bradycardia, AV block, shortening of the QT interval, and sometimes in the precordial leads the appearance of an Osborn wave. To identify the cause, lab tests are typically done, looking at parathyroid hormone, vitamin D, albumin, phosphorus, and magnesium levels. In hypercalcemia, the main goal is to lower calcium levels using medications that reduce calcium in the blood. One approach is to increase urinary excretion of calcium, which can be done by rehydrating an individual, which causes more calcium to get filtered out. In addition, loop diuretics can be helpful because they inhibit calcium reabsorption in the loop of Henle, leaving calcium in the lumen of the nephron to get excreted. Another approach is to increase gastrointestinal excretion by using glucocorticoids to decrease intestinal calcium absorption, which allows it to instead simply pass through the gut without getting absorbed. Finally, you can prevent bone resorption by using biphosphonates, or calcitonin, to inhibit osteoclasts. Alright, as a quick recap, hypercalcemia describes a high concentration of free ionized calcium in the blood, which most commonly results from excess parathyroid hormone, as well as malignancies. High calcium levels cause excitable cells to be less excitable, which results in slow reflexes, muscle weakness, and constipation.
Okay, well, that's quite useful. Thanks very much to osmosis.org for doing half my work for me. So I hope you found that a useful review of hypercalcemia, some which we see quite often and need to know the basic treatment and causes of. Okay, I might end this, and I look forward to joining you all for the next of these electrolyte short vignettes and clinical cases.